الخير جميعا. طيب هنستاذن حضراتكم بس الصوت عشان نبتدي الجلسه الثانيه. الكيس بتاعتي entitled Technical Success in Complex PCI What Else Matter. He was a 65 years old gentleman, diabetic hypertensive. He underwent PCI to LED in 2007 and was presented in May 2020 with very high risk non-STEMI in cardiogenic shock. He has a past history of ischemic stroke 7 months before this presentation. On examination, he was in frank cardiogenic shock or noradrenaline, referred from another hospital. He was confused. His ECG showed diffuse ST depression in all anterior leads, and his echo showed severely impaired LV systolic function less than 20%, ranging 10 to 15%. This is his coronary angio, as you can see here. Severe calcific LED lesion with severe in-stent stenosis, severe calcification in the OM branch with chronic total occlusion of the right coronary artery. So after this coronary angiogram, we did a heart team, very brief heart team discussion. Was a patient on table, and patient was denied from the surgeon due to very high risk of mortality. So he was planned for staged revascularization, and to optimize the outcome, we planned to do it IVUS guided, and he was electively intubated, and intra-aortic balloon pump was inserted. So I started with the LCX because I anticipated إنه ال LED هيحتاج شغل كتير و lesion preparation. I put the stent in the LCX, 2 overlapping stents, followed by IVUS assessment to the LED. If you remember, this patient has a total occlusion of the RCA. However, we thought in an intra-aortic balloon may offer some mechanical support. This is IVUS of the LED, starting here from the proximal 270 degree في calcification, 270 degree arc of calcium followed by 180 degree. This is the landing zone at the distal LED. This is a tight concentric stenosis and ISR with mixed plaque. I started by preparation with compliant balloon, followed by NC balloon 3x15 at very high pressure. Definitely I would not use the rotablation as this impaired hemodynamics. So I used the scoring balloon 3x10 at high pressure, and followed by IVUS run showed that the calcium was modified, and this was followed by deploying 3 overlapping stents, provisional left main to the LED with this result. However, we almost have no myocardial blush at all. IVUS assessment showed well-deployed stent with adequate minimal stent area. Patient was transferred to the ICU. On the second day, he was successfully weaned from mechanical ventilation. On the third day, intra-aortic balloon pump was prematurely removed due to peripheral vascular disease and signs alarming of limb ischemia, and inotropic support was adjusted. We started then for this patient. On the third day, patient creatinine progressively rised to 5 gram. Hemodialysis was started for metabolic acidosis and volume overload, and he completed 3 sessions. On 4th and 5th day, continued to show acidosis with unstable hemodynamics, and on the 7th day, he's arrested in incessant ventricular tachycardia, monomorphic VT, and did not regain spontaneous circulation, and death unfortunately was declared. So the learning of this case, cardiogenic shock complicated myocardial infarction carries a 30-day mortality around 50%. والنسبة العالية دي is reported worldwide في كل السنترز regardless expertise of the operators. Still, this entity carries a very high mortality. And despite advances in contemporary PCI, different registries still report the same number of mortality. والدياجرام ده سوري لو الصورة مش هتبقى واضحة قوي، لكن this is what we call the downward spiral in cardiogenic shock. So further hemodynamic impairment بيؤدي إلى more load on the LV with more oxygen demand, which is translated into more myocardial dysfunction, and the patient enters into a vicious circle and unfortunately large number of these patients die at the end of the day. So such patient with very bad profile, the question was, would he get benefit من more advanced mechanical circulatory support? The answer is I don't know. هل this patient putting him on ECMO, if available, could offer more help? Maybe. So الستيتمنت دي عجبتني. It is not my statement لكن I quoted it. بتقول إن while you are flying high on the feeling of success, never forget that failure may be encountered. So such achievement يعني في نهاية القسطرة كلنا كنا happy إن إحنا we achieved this excellent result from our point of view. However, this did not help our patients. So always be humble while facing these patients. So my take-home message is that cardiogenic shock complicated myocardial infarction is challenging in management. 50% mortality, however, should never deprive others from the invasive strategy. So while technical success is to open the occluded artery or the culprit artery with minimal residual stenosis, procedural success is a technical success with no MACE, and our goal should be both of them. Thank you very much.
شكرا دكتور مايكل على البرزنتيشن. دلوقتي احنا الاستراتيجي في الكارديوجينيك شوك culprit only مش كده؟ يعني احنا just do the culprit وما نتفلسفش ونروح في حتة تانية علشان الكالبريت شوك طلعت انه الكومبليكيشنز اعلى والرينال فيلير والمورتاليتي اعلى، فبالتالي it's better طالما في كارديوجينيك شوك just culprit only.
هو بس this patient was a non-STEMI patient, so we couldn't identify. Yes, we couldn't identify a true culprit. Okay. وعندنا total occlusion of the RCA. So our strategy we thought إنه fixing the LCX would offer some support لأن ال LED كان هياخد aggressive.
في الSTEMI إنك أنت ما عندكش culprit واضح. في حد ليه أي استفسار دكتور مايكل؟
Thank you.